So lipoprotein is a ApoB-containing lipoprotein that is thought to be causally related to the risk of cardiovascular disease. But its role in clinical medicine and its clinical relevance has been debated for more than a generation. And that issue now is somewhat more urgent because there are specific antisense oligonucleotides and RNA interference molecules that are currently in development that specifically and potently reduce Lp(a). So the question really becomes, how much do we have to lower Lp(a) to produce a clinically meaningful reduction in risk in a short-term trial, which will help us identify which patients are most likely to benefit from lowering Lp(a). Now, previous research has suggested that the effect of Lp(a) on the risk of cardiovascular disease is proportional to the absolute reduction in LDL, and that very large absolute reductions are required. But the precision of that estimate of how much we have to lower Lp(a) is really problematic for two reasons. First, the assays are not specific, and the amount we have to lower Lp(a) may be specific to each assay, particularly when measuring Lp(a) in mass, as represented by milligrams per deciliter. But also because the ApoA moiety of Lp(a) appears to have a sequence homology with plasminogen, and therefore may be prothrombotic. So the question really becomes, if it is prothrombotic, then perhaps an aspirin or other antiplatelet agent or an antithrombin agent could substantially reduce the risk of atherosclerotic cardiovascular disease associated with elevated Lp(a), and therefore substantially impact how much we have to lower Lp(a) to reduce risk. So with that in mind, we recently conducted a study to address both of those issues.
To answer these questions, we included 480,000 participants of UK Biobank, of whom 375,000 had an Lp(a) measurement, making this the largest study with one single isoform insensitive assay to date. So what we found was that the equivalent change in Lp(a) to 1 millimole lower LDL cholesterol was a change in lifelong Lp(a) of roughly 170 nanomoles per liter. And finally, we wanted to address the question whether antiplatelet therapies or anticoagulant therapies could possibly affect Lp(a) on cardiovascular disease. And what we found was, first, using a polymorphism associated with an inhibition of platelet aggregation, that comparing carriers versus non-carriers of this polymorphism, that the effect of Lp(a) was essentially the same. And second, we created a genetic score of genetic variants in the thrombin and in the factor V gene, and this score was associated with a stepwise decrease in the risk of venous thromboembolism. And we found first that in each category of this score, the risk of Lp(a) on cardiovascular disease was the same. And second, we performed an analysis where we looked on the association of Lp(a) with venous thromboembolism, with deep vein thrombosis, and with pulmonary embolism, and there was no association.
So this research really resolves some important biological questions. It doesn't appear as if Lp(a) has a clinically meaningful prothrombotic effect across the broad range of spectrum within 99% of the population. In addition, it has direct implications for the design of those trials. Because very large reductions in Lp(a) are likely to be required to reduce the risk of cardiovascular events, almost all of those trials will enroll secondary prevention populations in order to have a reasonable event rate within a short-term trial. Almost all of them will be on single, perhaps even dual antiplatelet therapy. It is unlikely that antiplatelet therapy is likely to affect the risk of cardiovascular disease associated with Lp(a), and therefore unlikely to attenuate the benefit of Lp(a) lowering therapy.